We can see the slides. Those people are here already. Can we see the slides?
Yes, Dr.
Yes.
Ken.
Yeah, okay. So I'll just go through again what I was saying because I was rushing through because I could see the time. So we know that everyone should get a blood group, all of us, to know what's going on, because the problem only arises when a Rhesus positive man makes a Rhesus negative girl pregnant. That's the only time this problem arises. So we said already that we give this routinely at 28 weeks, at 34 weeks, and within 72 hours of delivery. Or we also give it whenever there's a sensitizing event, and we described those sensitizing events. They are here. Trauma, antepartum hemorrhage, if you are transfused with the Rhesus positive blood and your Rhesus negative, when there's an abortion, when there's an ectopic, when there's a molar, and this molar should be a partial molar pregnancy. When you have a complete molar pregnancy, you don't need anti-D because there's no fetal tissue in a complete molar pregnancy. And then when you have a fetal death, and then there are those procedures, chorionic velar sampling, amniocentesis, and also ECV. These procedures we don't normally do in our setup. So that's about that. So we were talking about the dose. So for every ml of fetal blood that crosses over to the maternal circulation, you have to give 30 micrograms of anti-D or ROGAM, as it is called. So sometimes you need to give a bit more than usual because this 300 micrograms that we routinely give at delivery and 28 weeks and 34 weeks assumes that only 10 mL of blood might have crossed over from the fetus to the mother through the placenta. But sometimes in some occasions, that assumption is not correct, like in a abruptio placenta, or when somebody's having a cesarean section, when there's a manual removal of the placenta, when you have a twin pregnancy, there might be more blood that has crossed over from the fetus to the mother. So you might need a higher dose. So you do what is called the Kleihauer-Betke test to determine how much more anti-D you have to give above the normal 300 micrograms dose. So the way a Kleihauer-Betke test is done is that they remove blood from the mother, and then they put that blood under a microscope. Then they subject acid to the blood. So we know that fetal red blood cells are resistant to acid, and maternal red blood cells are not resistant to acid. So what will happen is the maternal red blood cells on a slide will look white, but the fetal red blood cells will look still red with hemoglobin in them because of the fetal hemoglobin. So we are able to tell what percentage of fetal red cells are in maternal circulation by just counting the number of fetal cells we see on the slide. So we can calculate the percentage. What is the percentage of fetal cells? That is the maternal blood. Then we multiply that by the maternal blood volume to determine the amount, the volume in mL of fetal blood that has crossed over. Then we use that to calculate the dose. Since we know the dose is 30 microgram for every ml that has crossed over, meaning that once you calculate this dose, then you can compare. You only gave 300. How much more do you need to give? So normally that's how that is calculated. Then we need to know that not everyone gets anti-D. Only the mothers that are not sensitized. So the mothers that are not sensitized get anti-D. The ones that are sensitized can't get anti-D because their immune system already has a memory of anti-D, of the D antigen. So there's no way of reversing that. So if you give anti-D, you're just wasting, because this woman already has anti-D antibodies in her circulation. So you find out if somebody is sensitized using what is called an indirect Coombs test. And we can all read about how to do an indirect Coombs test. So if it's positive, it means the mother is sensitized and she doesn't need to get anti-D. If it's negative, it means she's not sensitized, so we can go on to give her this anti-D. So that's an example of anti-D. And the question is that how is it given and how does it work? So anti-D, I've put that funny example there. And what that means is that anti-D is like you just inject antibodies into the woman's circulation from outside. So these are foreign antibodies. They are not produced by the woman. So you have injected this woman with these antibodies. And therefore, when the red blood cells of the fetus seep into the woman's circulation, these antibodies quickly attach to these red blood cells, and the reticuloendothelial system clears the red blood cells quickly. Before the real circulation, the circulation of the real immune system gets to know about these red blood cells, they've already been destroyed. So it's like destroying the evidence that the red blood cells, these foreign red blood cells, were in circulation before the real immune system gets to know about them. So that is how anti-D works. So you put antibodies there. If the red blood cells of the baby seep into the maternal circulation, they are quickly attacked by the antibodies. But these antibodies are antibodies that came from the outside. So they attach to these antibodies. They don't get to go to those antigen presenting cells. So the immune system really doesn't get to know that these fetal red blood cells were there. So they get destroyed before the antigen presenting cells get to have access to them. So that is how generally anti-D works. There are other mechanisms that are described, but I think this is the simple one to explain. Yeah, so that's how it works. And usually it's given IM and it's given on the deltoid. If you are going to give it IV, there are some formulations that are given IV, and it's usually in people with like who have hemophilia, and if you give them IM, they would bleed in that muscle. So that's why usually anti-D is given IM. It's only given by IV when you have somebody who has a coagulopathy, like somebody with hemophilia, and they're Rhesus negative. Those are the ones that get to have the IV version. And then you need to be careful about reading on the package. The one I've shown you here, it says that this is for intramuscular injections only, but there are others that they write that you can give by the intravenous route. So what do you do when these women are in labor? So you have to make sure you avoid unnecessary VEs, avoid unnecessary abdominal palpations, because that manipulation of the uterus when you are palpating unnecessarily can cause some of the blood to seep from the baby to the mother. We never know. Avoid unnecessary instrumental deliveries. Do active management of the third stage of labor. Avoid manual removal of the placenta. During cesarean section, you have to pack the abdomen to avoid blood from the fetus going into the mother's abdomen, because the mother will absorb these fetal red blood cells and she'll become sensitized. You need to cut the cord long. You need to avoid milking the cord. And when the baby is born, you need to do blood grouping for the baby. If the baby is Rhesus negative, there's no need to give anti-D after delivery. If the baby is positive, you need to give anti-D. We already said you need to give within 72 hours of birth of the baby, or if there's a problem, big problem, then you can give it up to 10 days. If delivery has been complicated, you might need to give a higher dose of anti-D, like we described, than 300 micrograms. And then you need to avoid igometrin, because igometrin causes a sustained contraction, and that can cause some of the fetal blood to seep into the maternal circulation. Because you only need 0.1 mils of fetal blood to seep through for this sensitization that we've described to happen. So that is about that. So that's what we do. So this is an example of a baby who has hydrops fetalis. So that is edema of all the organs. Usually you need fluid in 2 organs for you to say that you have hydrops. So pericardial effusion, this baby has ascites, this baby has skin edema, this baby has liver edema, this baby has spleen edema because of anemia that resulted from anemia. And when these babies are born, they can get kernicterus gravidarum. So that is about hydrops. So that's how these babies are born when they get this disease, and it cannot be cured really once the baby is born. So this is a big problem. So how do you handle, so this is a slide, I think it's the last slide, on how do we handle a sensitized mother. So this woman is already sensitized. She already has antibodies in her circulation because she had exposure to fetal red blood cells. What do we do with this mother? This is a difficult situation in our setup. That's why we need to, when I gave a slide on prevention, we need to concentrate on preventing sensitization by giving anti-D to women who are not sensitized. So we cannot do antibody levels in these women because that's what people are doing. They do antibody levels and then they can advise the woman on what is the prognosis for a baby, but we can't do our antibody levels. If we go to the private labs, our patients cannot afford it. Then the other thing is that the baby as it grows needs to be monitored by ultrasound. So you're monitoring for features of anemia because there's hemolysis going on. And usually we do middle cerebral artery Dopplers. And there are very few places you can point at which do competently these middle cerebral artery Dopplers to determine how anemia in the patient. So, and the mothers have to pay a lot of money for these procedures and they cannot afford it. So there are few places to do middle cerebral artery Dopplers, and those few places the mothers cannot afford it. Then when the baby is already anemic and the baby cannot survive outside, like it's before 28 weeks in our setup, before 30 weeks, you need to transfuse that baby, but you need to transfuse it intrauterine. And we cannot do intrauterine transfusion for these mothers. So what we normally do would just be monitoring this mother using ultrasound to see if the baby has any features, placental edema, is there liver edema, is there spleen edema, is there ascites in the baby? So somebody can be doing those scans. And when the baby is able to survive from outside, in the outside, we just deliver that baby. We need to give dexamethasone quite early to help with fetal lung maturity, but really there's very little we can do for that sensitized mother. Some people used to do amniocentesis to check if there is bilirubin in the amniotic fluid and so on, but these things are things that are not done routinely. So for us, the most important thing is making sure that our mothers are not sensitized. We give anti-D and we do those things that we need to do in labor to prevent these mothers from being sensitized. For us, that's the way we need to go. We need to make anti-D available for all the women on our labor wards. Otherwise, once they are sensitized, there's very little that we can do for these patients. So that was the last slide. Maybe if somebody has a question in the next just 5 minutes, I think we've been talking for a long time, then we can stop. Yeah. So are there any questions?
Doc, I'm sorry for taking you back, Doc.
Yeah.
Unfortunately, I missed the part where you explained on the mechanism of action of anti-D. I think I had a network problem at that point.
Okay, so what I explained as the mechanism of action was the simplest mechanism of action, but people argue so many mechanisms of action. But the way to think of it is that you've given the mother antibodies. You've given the mother this anti-D at 28 weeks. So we also say that you only need 0.1 mils of blood to seep through the maternal circulation for the mother to be sensitized. That's very little blood. So when this blood seeps into the maternal circulation, the antibodies are already there. So these antibodies will get attached to these red blood cells. And then since there's an antibody-antigen complex now, the red blood cells have antibody attached to them. The immune system of the mother, through the spleen, the lymph nodes, they will destroy these red blood cells very quickly before the antigen-presenting cells capture these antigens and process them and go to inform the lymph nodes, go to inform the B cells, so that really what has happened is that the red blood cells have been cleared from the maternal circulation before the immune system of the mother gets to know what's going on. That's why I used this example here, that it's like destroying the evidence that the red blood cells were ever in that circulation before the real police, which is the real immunity of the mother, gets to know about it, because the foreign immunity, which is the anti-D that we put in the mother, has already cleared those red blood cells before the immune system of the mother gets to wake up, for lack of a better term. So that's how we describe the mechanism of action. I know it's simplistic, but that's how, that's the simplest mechanism of action that I've seen.
All right, thank you, Doc. Thank you.
Yeah, is there any other questions? I understand this is a very technical topic, but you need this is just basics for you to have the basics in order, so that when you go and read, you just build on the basics, then it becomes easier to read. Okay, any other question?
Doc,
Yes.
I have a question.
You can go on.
On the women to administer anti-D to, do we need to check the blood group for the woman and for the man, or we just administer to anyone who comes to our antenatal clinic?
Can you ask that question again?
I'm saying on the eligibility criteria for those who to receive anti-D.
Yeah.
We need to check the blood group for the woman, pregnant woman, if it has got a Rhesus negative, and for the husband, if it has got a Rhesus positive, for them to be eligible to receive the anti-D, or we just administer to anyone who comes through our antenatal clinic.
Okay, so like we said, this anti-D is only given to Rhesus negative women. So you need to, because they are the only ones that can develop this problem. So you need to, that's why we do blood group for all women who come to the antenatal clinic, to find out who's Rhesus negative, so that we can give the anti-D like we described it at 28 weeks, at 34 weeks, and at delivery. So that's the first point. So we only give anti-D to Rhesus negative women because they are the only ones that are going to have this problem. Then your second point is the partner. So about the partner, the issue with the partner is that if somehow you are very, very sure that the partner is the father, then you can skip anti-D. If the partner is, you know the partner, and you know that the partner is also Rhesus negative, then you don't need to give anti-D, if you are sure that's the situation. But in our society, we are never sure of who the father is. We are only sure about who the mother is. So we give every woman who's Rhesus negative, regardless. In fact, we don't even ask what the Rhesus status of the partner is. Because, you know, what if we find that when the baby is born, the father is Rhesus negative, now the baby is Rhesus positive? It means that that's probably not the baby to that father. So we normally skip that debate. Unless the woman herself says that her partner is Rhesus negative and she's very sure about the fact that he's the father and she doesn't want to receive anti-D. Then we don't give. But practically, everyone who's Rhesus negative, every woman who's Rhesus negative, we advise them to get anti-D. We don't even ask about the Rhesus status of the partner. But once you explain the disease, sometimes the woman will tell you that, no, but my partner is Rhesus negative and I'm sure. Then you don't have to give, because she's the one who's volunteered that information and she's sure. So it means that you're giving her medicine for nothing. So having said that, we need to know that anti-D is expensive. It's somewhere in our setup around 1,000 kwacha, I think, around per injection. So 1,000 means that the woman will need to organize at least 3,000 kwacha for the 3 injections, and she might need to have another 1,000 for any sensitizing events. So anti-D is quite expensive for our women to afford. That's why I think it just needs to be available on the ward for all the women that are Rhesus negative, because they are not a lot. Yeah, so that's the answer to that question. Is there any other question?
Yes, about the
Thank
question.
you so much, Doc.
Is isoimmunization and alloimmunization the same? Or is there a
What?
difference? Is isoimmunization and alloimmunization the same?
And alloimmunization.
Yes, are they the same? Or there's a difference?
Alloimmunization and isoimmunization.
Yes, what's
That's
the
what
difference?
you're asking. Yeah,
Yes,
I think they are the same, but alloimmunization is more, I think what they are saying when they say alloimmunization is that antibodies, that's what I think alloimmunization means technically, that antibodies produced in another human being are causing problems in another human being. I think that's the issue. So antibodies that were produced in the mother are now causing a problem in a baby. That is a different human being altogether. So I think there are similar terminologies, and you can use them kind of interchangeably, but alloimmunization has that technical meaning that I've just described, that you are talking about antibodies from a different person causing problems in a different person. So the baby didn't produce the antibodies that are destroying its own blood. In this case, it's the mother's antibodies that are causing the destruction of the fetal red cells. But I think I need to check out that, and maybe you need to check that one out and tell me. But I think that that's the technical difference when you say alloimmunization specifically. There's that connotation that is with that terminology. Yeah. So, but like I said, let's all check that one out. Is there any other question?
Not really a question, but asking on the, I think I don't know if we are not told or I missed it. I didn't hear the lecture on the cesarean section. So I'm asking if the recording is there, you can give us, or if the notes are there.
On cesarean section, yeah, if you check on that,
yes.
if you check on that YouTube channel, I think it was shared. Just go, right. Just go to that YouTube channel and look for cesarean section. You'll find it, it's there, yeah. So we already talked about
Thank you.
abdominal vaginal delivery. Today we talked about vaginal operative delivery. We already talked about abdominal operative delivery. Yeah. So that's that. Is there any other question? So I'll post all these also on the same YouTube and I'll share it. I don't know even now to share it because I don't know which are here, but you can just check on that channel and share it with whoever wasn't there. I think there's enough people on the forum to have it shared to other people. Okay, so we started at 16, this is 17:45. So we've been here for 1 hour, 45 minutes, which is not bad for like 4 topics. So I'll try and organize another one just to cover more topics within the week, because it's difficult to find time for all of us, for you and for me. So if we can do 4 topics, 3 topics in one setup of 1.5 hours, then it's easier for all of us. And then we've recorded, we share, we can all go back and read more. Yeah. Okay, so thank you for being there, the ones that were there. So I'll share the slides after this. Okay, if there's no burning question, that's the end. Thank you.
Thank you.